All right, let me pull up her slideshow here and we'll get started. Hi, everyone. As Erin said, I'm Sarah Halliburton. I'm the respiratory epidemiologist, and I act as the influenza surveillance coordinator for the state. So today I'm going to cover a few topics on flu. I'm going to go over just a brief recap of last flu season, some flu vaccine updates, where we're at in our current season, talk about influenza-associated deaths, and then prevention strategies in healthcare settings. So for the 2018-19 influenza season, Indiana's flu activity peaked during week 11 or the week ending March 16, 2019. The influenza A viruses were split pretty evenly between A H1N1 PDM and A H3N2. We had 32 long-term care facility outbreaks of flu reported and 8 school outbreaks, and then 113 reported flu-associated deaths. This graph depicts our percent of patients seen with an influenza-like illness or ILI from our outpatient sentinel sites. So last season is that solid green color. You can see that we had our first peak around week 52, and then it dropped a bit, but was still elevated for several more weeks until it had a final peak during week 11. And what is interesting about last season is that for the first half of the season, it looked like influenza A H1N1 was the predominant virus until after that first peak. And then after that, the H3N2 viruses started to pick up, and then they took over in circulation while the H1N1s decreased. So the second and higher peak is mainly the H3N2 activity. I will touch more on this when I get to the flu vaccine efficacy slides. So we were actually above baseline activity level for 16 consecutive weeks in Indiana last season, but nationally we were above baseline for 21 consecutive weeks. So although last season was overall moderate in severity, it was actually considered the longest flu season in a decade. So this graph is showing our trends for emergency department visits for ILI. We also have a few urgent care facilities in there. Last season is the light green color, and similar in that peak was for week 11 for ED visits with a chief complaint of ILI. The first smaller peak was also during week 52, just as we had for our sentinel sites. The larger peak at week 11 does coincide with that increased H3N2 activity, which those viruses are known to be a little more burdensome than the H1N1. So this is just a table that has the breakdown of our deaths by age group. So you can see that about 75% of all of our deaths were in people age 65 and older, which is pretty typical for what we see every year. This is our virologic surveillance done at our ISDH lab. So these are detected flu viruses tested throughout the season at our lab, and you can see in that red box, it was by the end of the season, it was split very evenly. So right down the middle between the H1N1 and H3s, and very little B Victoria or B Omega activity. So to switch over to flu vaccine updates. For flu vaccines, we have our trivalent and quadrivalent inactivated influenza vaccines. So those are generally intramuscular. We also do have the live attenuated influenza vaccine, which is the nasal mist, but that is a limited supply this season. But for the injectable vaccines, so we have two types of influenza A viruses. We have the H1N1 PDM and the H3N2, and then one B virus, the B Victoria, is in the trivalent, and both B viruses are in the quadrivalent vaccine. So an annual influenza vaccine is always recommended because immunity does wane after about a year, and then our circulating viruses do undergo antigenic changes. So, and also even if the vaccine is not a perfect match or is not offering complete effectiveness, it can protect against severe complications and death. So this was last season's flu vaccine components, and in that red, what's highlighted in the red font is indicates the changes from the season prior. So the H3 and 2 and the V Victoria were different from the 2017-18 component. Last February, so every February we have our interim results for vaccine efficacy that CDC releases. So our interim results for last season, which was through February 15th, 2019, it at the time indicated vaccine effectiveness of 47% against medically attended influenza, but the end of season results indicated that the overall effectiveness was about 29%. So that was quite a bit of a drop, and I'm just going to explain kind of why that was. So the vaccine efficacy for H1N1 viruses largely remained unchanged between the preliminary results and final season results, but the H3 and 2 started out showing a 44% vaccine efficacy, then dropped to essentially zero. And so this I'm going to kind of try to explain why that is. On this graph, the yellow bars are the H1N1s and the reds are the H3 and 2. So as I said earlier, last season was split between the H1 and the H3. So the first half we see mostly H1N1 activity, and then as those are dropping, the H3s are picking up for that second half. So when the preliminary results did come out, the H3 and 2 was a pretty good match because one, there weren't that many circulating, and two, what was circulating actually was kind of matching what was in the vaccine. But as the H3 and 2s actually took over, they had a shift in the season. So they drifted away from what was circulating at the beginning of the season. And on this graph, you see the green line is this subclade, so of a 3C, 3A subclade. And as the season went on, those took over of the circulating H3 and 2 viruses, and that was very genetically distinct from what was in the vaccine. So by the end of the season, all the H3 and 2s that were circulating did not match the vaccine component. So that's why the vaccine efficacy dropped so much. So to talk about the components of this season's flu vaccine, the A virus components had changed. So the H3 and 2 virus was changed to try to match that 3C, 3A subclade that became prominent the last half of last season. And then our interim vaccine efficacy results should be available by mid-February. So look out for those. So to switch over to where we're at in this current flu season. For our sentinel site data, you can see this season's activity in the dark blue color. We have been over our baseline since the end of November, and our influenza-like illness activity picked up quite a bit during the month of December, with a decrease after week 52. So ILI and sentinel site outpatients was 3.25% during week 1 or the week ending January 4th, 2020. For this season's essence data, which is the emergency department and urgent care chief complaints of ILI, we're also looking at the dark blue line. So typically, once we're above that 2% ILI threshold, we say that flu season is really here, and flu is going to be circulating above baseline for several weeks or months. So we've been above that 2% baseline for syndromic surveillance since the week ending November 23rd, 2019. And as of week 1, our chief complaints of ILI and ED and reporting urgent cares was 4.83%, which was actually a decrease from a peak that was seen in week 52. It's too early to say for sure if we've officially peaked for flu season or if we're going to have another peak later on. Because as you can kind of see, we've had a few seasons lately where we've had our first peak right around week 52 and then it picked up again about a month later. So right now we're at 22 deaths reported in adults, with the most occurring so far during week 1. And then this is, again, our virologic surveillance at ISTH lab. So this season, we're seeing mostly the H1N1 viruses and B Victoria. So very little H3 and 2 and B Yamagata circulating this year. So this is nationally. This map indicates the geographic spread of ILI. So as you can see, as of week 1, ILI was geographically widespread in most states. In Indiana, we've had widespread activity since week 48 or the week ending November 30th, 2019. And this map indicates the ILI activity level using the proportion of outpatient visits to healthcare providers for ILI with each state. So the majority of states were actually at high activity for week 1, and Indiana was listed as high activity for a few weeks, but then dropped back to moderate activity during week 1. And then last season, CDC started doing in-season preliminary burden estimates that they update every week. So for the week 1 updates, CDC's estimated that there have been anywhere between 9.7 to 14 million flu illnesses, 87,000 to 150,000 flu hospitalizations, and 4,800 to 12,000 flu deaths. So again, nationally, what are we looking at? Although influenza activity has been elevated for 9 weeks, hospitalization rates and percents of deaths due to pneumonia and influenza do remain low. And this is likely due to the predominance of the B Victoria and H1N1 viruses, because those are more likely to affect children and younger adults than the adults that are in that 65 and up age group. And generally, when we're seeing all those flu deaths, that's in the 65 and up age group. So we're going to be seeing fewer hospitalizations and deaths occurring in that age group. So we might see fewer deaths nationwide. Nationally, influenza B Victoria viruses are the most common, followed by H1N1 PDM, but the predominant virus does vary by region and age group. In Indiana, as of week 1, we did have 22 reported flu-associated deaths and 3 long-term care facility outbreaks of flu. There have been 32 pediatric flu-related deaths reported nationwide. No pediatric flu deaths in Indiana reported yet.
All right, so I think I saw some questions come in, so we can go ahead and take a break and answer those. So if anyone has any questions so far, feel free to type them into the chat box. Right now we have a question that says, do we know if the flu deaths in 24 to 49 were vaccinated?
I know the majority of the flu deaths that do come in are not vaccinated or the vaccination status. I believe there may have been a few in that age group that did receive a vaccine, but for the most part, you can't hear me. For the most part, people have not been vaccinated, or we just don't know. I couldn't find the record.
Can you hear us better now? Fading in and out. All right, we'll just talk up a little bit closer to the microphone. All right, any other questions for now? And we can answer the rest of the questions at the end of the presentation. All right.
Okay. So for reporting influenza-associated deaths, all influenza-associated deaths are reportable to the health department under our communicable disease rule. Um, Please report an NBS and fill out the morbidity report as much as possible when reporting a flu-associated death. I do get many that are almost blank, and some don't have influenza testing information or even a date of death listed. Attachments are also always appreciated. We do need or urge facilities to submit specimens upon ISDH request to our lab for further testing in the event of a suspected or confirmed influenza-associated death, although it is not mandatory. If an NP swab was performed for PCR testing, it can be submitted to the ISDH lab within 5 days as long as it was kept refrigerated. If the specimen was frozen, our lab will receive older frozen specimens as long as they are shipped and received frozen. And if there was no specimen taken before the patient died, a postmortem specimen can be taken via NP swab or tissue sample. If you do have questions regarding specimen collection and transport to our lab, please call the virology supervisor at 317-921-5843. So it is estimated that an average of 8% of the US population will have an influenza virus infection each year, on average. So that's roughly 26 million people across the country. And then many of those will go on to seek medical care. So, with that, what are some good infection prevention strategies for healthcare settings? The main prevention strategies include administration of an influenza vaccine, implementation of respiratory hygiene and cough etiquette, appropriate management of ill healthcare personnel, adherence to infection control precautions for all patient care activities and aerosol generating procedures, and implementing environmental and engineering infection control measures. So I'm going to go over those and a few more, and I do apologize if this is information you all already know. So about administering flu vaccines, promoting and administering an annual flu vaccine in both healthcare personnel or HCP and patients is key in flu prevention. So unless contraindicated, everyone 6 months of age and older should get an annual flu vaccine. And the link on the screen has some really great resources for health professionals regarding influenza vaccines. So taking steps to minimize potential exposures should instruct patients to inform healthcare personnel upon arrival if they have respiratory symptoms and to take appropriate preventative action. So wearing a face mask upon entry, following a triage procedure. Take steps to minimize patients seeking care for mild influenza-like illness who are not at increased risk of flu complications. So an example is providing telephone consult to patients with a mild respiratory illness to determine if they actually do need to seek medical care or if they can just stay at home. Try to ensure all persons with symptoms of ILI follow respiratory hygiene, cough etiquette, hand hygiene, and triage procedures. Provide face masks to patient exhibiting symptoms, providing hand hygiene supplies to all the patients. So at facility entrances and throughout the hospital, providing space for symptomatic patients to sit away from others in waiting areas, and then setting up triage stations to rapidly screen symptomatic patients and separate them from other patients. So monitoring and managing ill healthcare personnel. If possible, instruct ill healthcare personnel to not report to work, excluding from work until at least 24 hours after they no longer have a fever without the use of fever-reducing medications. Ill healthcare personnel without fever should be evaluated by occupational health to determine safe level of contact with patients. So if the employee is at work When ill, ill healthcare personnel should stop patient care activities, wear a face mask, and report their illness to a supervisor or infection preventionist. So if they're coughing and sneezing at work, they should wear a face mask during patient care activities. Remind ill healthcare personnel of importance of proper respiratory hygiene and cough etiquette, and consider temporary reassignment or longer exclusion from work if returning to care for patients in protective environments. And then in order to adequately do all this, it is important for facilities to develop sick leave policies that are not punitive and are consistent with public health guidance. So adhering to infection control precautions, all healthcare personnel should adhere to standard precautions during the care of any patient. But implementing droplet precautions for any patients with suspected or confirmed influenza for 7 days after illness onset, or at least 24 hours after being free from fever and respiratory symptoms, whichever is longest. And then place patient in a private room or area if available, if not, cohorting patients with same illness if needed. Healthcare personnel should wear a face mask when entering a room of a patient with suspected or confirmed flu. Patients need to wear a face mask if possible and practice proper hygiene if being moved outside of their room. And then if a patient is ever being moved, transferred to another area, just letting the other people know, just communicating appropriately about the patient information and that they're under droplet precautions before transferring them. And then patients under droplet precautions should be discharged when clinically appropriate, but also communicating their diagnosis and precautions to anybody that is transporting them outside of the hospital or for post-hospital care providers. So performing aerosol generating procedures. Some procedures can generate higher concentrations of infectious respiratory aerosols. So for patients with flu, like bronchoscopy, intubation, suction of airways, CPR, etc. They should only be performed if medically necessary and if they can't wait for a later time. Limiting the number of healthcare personnel present during the procedures, and having no unprotected healthcare personnel in the room during the procedures. Conducting procedures in an airborne infection isolation room when feasible. And then healthcare personnel should follow standard precautions and wear respiratory protection, such as an N95 respirator or equivalent, and then following environmental surface cleaning after these procedures. So for visitor restrictions and access, for people with acute respiratory symptoms, facilities should develop their own visitor restriction policies that consider the location of the patient being visited or circumstances such as end of life situations.
I almost called you then. I'm on a WebEx, but it's okay. I almost called you the other day just to say you.
Sorry. Screening visitors for symptoms of acute respiratory illness before they enter hospital. Providing instructions to visitors on PPE, limiting surface touch and hand hygiene.
Please.
How are you doing?
Well, just that rules.
No, not
Oh,
oops,
my
sorry.
hands are full, Fred.
Yeah.
Okay. All right. Well, while we're here, there's been another question. It says, has there been any more discussion within the state regarding support for mandatory healthcare provider immunization?
So I have not been a part of any discussions about that. There could be discussions in our immunizations division, but that's not something I've been on, so I don't know. Okay. So back to visitor access and restrictions. Visitors shouldn't be present during any aerosol generating procedures, and they should be limiting their movements within the facility. And then advise visitors on flu vaccine if you're able to. Some facilities actually do offer free flu vaccines to family of patients that are hospitalized. And with visitor restrictions, this is a question I've been asked before. So what is the percent of emergency department visits for ILI to decide when to initiate or end visitor restrictions? So the answer is there actually is no set threshold. It does change every year. Hospitals can look to their local health departments or their regional Indiana Patient Safety Coalition. So each of the 11 IPSCs work to make a start date for visitor restrictions, but some areas or individual facilities actually will want to start earlier than those. So monitoring influenza activity. Facilities should establish mechanisms where healthcare personnel are alerted in case there's any facility outbreaks or increased ILI in the community. In this instance, communicating with your local or state health department is key. And environmental infection control. So standard cleaning and disinfection procedures are adequate for influenza virus environmental control in all settings within the healthcare facility. So that does also include the aerosol generating procedure. And then considering engineering controls. So to reduce or eliminate exposures by shielding healthcare personnel and other patients from infected individuals, installing physical barriers to reduce exposure. So partitions in triage rooms, curtains drawn between patients in shared areas are good ideas. And then just ensuring correct air handling systems are installed and maintained in the facility. For all healthcare personnel should receive job specific education and training on preventing transmission of infectious agents. So for flu, it would be good to have training on influenza signs and symptoms, patient risk factors or complications, and then the roles of vaccination, respiratory hygiene, and cough etiquette in the facility, appropriate use of PPE, and the use of engineering controls or other infection control procedures. Influenza antivirals and chemoprophylaxis should be administered when appropriate. So people treated with flu antivirals, it's important to still remember that they do still shed the virus while on the treatment. So they should always maintain hand and respiratory hygiene and cough etiquette practices even during their treatment. And then we have our last bit of information. For healthcare personnel that are at higher risk of complications from influenza, so that could include pregnant women and women up to 2 weeks postpartum, people 65 and older, and people with chronic diseases or the immunocompromised. So any healthcare personnel that might fall into that, they should receive an influenza vaccine and get early treatment with flu antivirals. That's what's recommended. And it should be considered that they can have work accommodations that reduce potential high risk exposure scenarios to these employees. And lastly, just always remembering to follow the 3 C's. So besides getting a flu shot, it's clean, cover, contain. Clean, so wash your hands often with soap and water. Cover is covering your coughs and sneezes, and contained by staying home when you are sick. This is my contact information in case anyone has any questions or comments for me. Also on Fridays, I release the weekly influenza report, so check out that on our weekly influenza reports page. And thanks for your time.
All right, thank you, Sarah, so much for presenting today. Does anybody else in the audience have any questions for Sarah? If you do, go ahead and type them into the chat box. All right, looks like no more questions. Thank you all for joining, and we will see you next time.